Good. So, great. I would now very much like to stop sharing my screen. I'll leave that in the background for you to put your questions there. And I'm delighted to welcome Jen and Justine, who are going to introduce them properly and the work that they've been doing.
Thanks very much, Rachel. So yes, I'm Jenny Wood, work for the strategy unit in the strategy and change team, and I have been kind of project managing this work that we've been doing, or kind of a suite of work that we've been doing to try and help analytically understand the opportunity or the requirements for left shift. Justine, do you want to introduce yourself?
Yeah, sure. So hi everybody, my name is Justine and I'm an analyst at the strategy unit. So I've been involved across all this suite of community reports, but other analysts in the team have been contributing and actually doing the work on the individual projects.
Thanks very much. So I'm just going to give a look, before I start sharing slides, I'm going to give a little bit of context. So most of you will be aware that Lord Darcy's the Darcy Review had suggested 3 big shifts, and one of those is the shift from acute to community, and there's a very related shift in relation to increased prevention. And we were approached by NHS England to try and use some techniques that we've been developing to try and analytically understand what that opportunity is, how much activity could potentially come out of acute hospitals and be met and have patients' needs met more effectively outside of hospital, ideally at home or close to home. Because we know that it's a big opportunity, we also know that it's an ambition of the health service for many years. Some would argue back as far as 1975, but certainly a lot of policy since the year 2000 or so. And it's something that hasn't necessarily happened in the way that we would have expected historically. So we wanted to use many of you all know that we've been involved in building a new hospitals program demand and capacity tool, which looks at how we expect changes to demand to happen into the future for acute settings. And because that's a very complex tool that has a lot of line level data in it about the acute activity that's happening and what's likely to happen in the future, we have been able to try and use that to estimate who and what activity might be able to shift. So what's important to say about this before I kind of kick off? There's a few things. When we're talking about left shift, which is a term that lots of people hate, but when we talk about moving care out of community, I think that the reason that people are really attracted to that is because it seems to be both an opportunity to make a saving on the one hand, but also a really important opportunity to correct a trend that's been happening that might not be good for patients. We know that patients often prefer to receive holistic care outside of hospital, and that hospitals really should be a location of last resort. So it's really important to do that. One of the key criticisms that happens in this area is that when we look at community services and primary care, we tend to take that view that we use to look at acute settings and just kind of transfer it over, and that the left shift can be thought of as really and that we focus a bit too much on what the effect on the acute hospitals is going to be rather than what the effect on the patients is going to be. And what you're going to see today is really focused on the interface between the acute setting and community. So we're not, unfortunately, going to be able to kind of look at the holistic picture, but what we're hoping is this is the start of a long process of developing tools, developing analytical ways of looking at things, trying to help add knowledge and understanding into systems that will allow us to move this agenda forward for the benefit of patients. So if you are watching this and thinking this is all very acute focused, that's because where the data is good at this point in time, and we're hoping to kind of create a bit of a shift. And I think that's partly why we were asking about CSDS, and you'll see it in a minute. The other thing I'm asking you to think of as a caveat, and I'm almost tempted to make everybody solemnly swear that they'll bear this in mind. We were asked to do this in 6 months, which seems like quite a long time for most projects, but actually for something this complicated, it was a really short period of time. It was, we were approached by NHSE. We didn't have very much time to turn it around to try and inform the spending review and the 10-year plan. So there are some simple maths, some shortcuts, some estimations that definitely could do with better techniques to deal with them in the future as we iterate forward on this. But it feels like this hasn't been something that we've done before, and that having a starter for 10 is where we want to put this. So please be kind of kind when you're looking at this, but hopefully you can see that there's some value in what we've got here. We're kind of going to do this in a number of parts and stop for comments and chat at various points. So hopefully you'll have an opportunity to ask questions there. And Rachel, do help us with that, will you, in terms of things that might appear. I can see the chat, but you'll be able to see the Menti. And so that's probably the best way to manage questions. But we, as Rachel said, we are interested in questions and challenge. We are interested. This has gone down very well with the policy audience, but analyst audience is really, really important for us in terms of how we can improve this and how we can also scale and spread it, because as many of you all know, in the strategy unit, we're kind of keen to make sure that we're giving other analysts the opportunity to use our work, and that we're kind of interested in building the capabilities of the NHS as a whole. So your challenge is really useful to us in terms of how we can share this work and make it better. Anything you want to add before I kick off, Justine?
No, I think you're good.
Great. I'm tempted to try and do Rachel's fancy presenter view, but I'm not going to do that. So we'll start at the beginning. So yes, the scope of what we're talking about here is estimating future demand for community services, including scaling the possible left shift. So the way that we wanted to break this down was to firstly ask, what's the likely impact of demographic change on core community services demand? So we know that we've got an aging population. We know that the demographics are going to affect what the need is for community services. If we're asking community services to also accept a bunch of new activity from acute hospitals, then we need to consider it in the context of the growth that needs to happen just to meet the needs of the population they're already serving first. So first, we're going to talk about demographic change for community services. The next thing we're going to talk about is what activity could move from the hospital. So we are the NHP, the New Hospitals Programme Demand and Capacity Model, has a number of ways of looking at cohorts of patients for whom we think there's an opportunity to shift their care. I've been told that I can't call them mitigators anymore. I got a virtual hand slap yesterday, but we use this term mitigation because it feels like these are actions that can be taken by systems as a whole to mitigate or reduce future demand for acute hospital services. So we'll talk about the ways that we tried to think about that and how we tried to scale it. And then finally, what does this mean for community resources, and what's the residual requirement for hospital capacity? So where do we end up in terms of how much demand there is for hospital services, but also what, if we are going to do the left shift, what does that mean for growth in community services? And here we're not thinking about things like productivity increases or different ways that systems can adapt to meet this need. We're just kind of total numbers. If you took the work from acute and put it into community, what does that mean for the volume of activity and how much it might cost? So first of all, we're going to talk about the impact of demographic change. Like I said a moment ago, community services need to accommodate the growing and aging population if we're going to be able to not worsen what's happened, the quality of care that's already being provided in community services. So we have developed some ways of looking at that, particularly based on CSDS, hence the CSDS conversation at the beginning. I'm going to hand over to Justine, the proper analyst, for this bit.
Thanks, Jenny. So if we want to consider sort of what the level of demand for community services would be in future, we sort of first off, we want to think about what the current sort of level of demand is. So on this slide here, this is what we're trying to do. We're trying to understand the current utilisation for community services. I should mention, I think Jenny said that there was a 6-month sort of period for this work, and there was for the whole suite. But this particular piece of work around demographic growth was the sort of first one, unfortunately, the first one to be due. So we had a bit of a shorter period. I think it was about 6 weeks maybe, but part of that was unfortunately over the Christmas period as well. So the work we've done here is sort of necessarily quite rapid. So just to provide that extra context. So I was quite interested actually in the Menti poll in the beginning. My working assumption had been sort of like 100%, 90% of people would say that they'd used the CSDS data previously. So I might just take a little bit of time, as it was a bit more of an even distribution, just to talk that through. So the CSDS collects information on the sort of contact level. There's lots of other pieces of information as well, but essentially looking at patients who are interacting with community services. It can be analytically a bit of a tricky data set to navigate, and also I think it's often described as still maturing. So there are some gaps that we need to be really sort of wary of analytically. It has, I think, vastly improved over recent years. So there are a lot of positives, but I think it's still, you would want to be very careful with any messages in terms of the actual quality of the data there. So what we did was we didn't use the whole of England, we used the National England data set, but we identified a subset of data which we deemed to be of good or consistent quality. So all of these results are presented on that basis, but we do a reconciliation back, which we've got a slide on as well later. So here we've looked at patients in our baseline year, which was 22-23, who had at least one contact with community services. So these are the sort of active patients in community services in a year. And we looked at the average number of contacts they have in a year by age. So you can see, sort of probably no surprise, that the older the community patients, the more interactions that they're requiring with community services. So this represents the current baseline. It doesn't sort of look for any efficiencies or any unmet need or any other sort of gaps between demand and supply. It's just describing the current position. We next go on to have a look at the population. So on the previous slide, we were considering our utilisation in the population, and now we're considering how the population's going to change. Here we're using the 2018 projections because that's the data that was available at the time that we were working on this analysis, but I know recent ones are around, so this probably slightly out of date from that perspective. And we're sort of looking at how the population is expected to change between our baseline year and our horizon year that the client was interested in. Again, probably no surprise, but we're seeing not much shift really in the younger age groups, but we're seeing proportionally big growth in the older age groups. And over that time period, the number of people in England who are aged 85 and older are expected to increase by half again, that 50% proportional increase there. When we apply that on the next slide to the actual utilisation, we did a worked example here because we were presenting to the client and sort of really wanted to make sure that they understood the method. So it's just some sample data just to illustrate how we've arrived at our calculations, probably not so necessary for this audience. But when we do that, then we look at the actual results of our sort of predicted growth, assuming that utilisation stays as it is. And again, no surprise, we can see that the biggest growth for community contacts is expected to be in the older population. I think it's important to note that overall this figure is 20%. So community services have a sort of growth requirement of 20% based on this calculation. But there are these different profiles across different age groups. So if we look at all adults, that same sort of change would be 25%. If we looked at people 65 and older, that would be 34%. And next slide, Jen. So in the CSDS data, we also have the team or the service type that the patient sort of was in contact with. So again, going beyond just looking at the headline 20%, sort of what did this growth look like by team? This is just adults here, which is what the client had wanted to see. And this shows that really it's no surprise, but the growth is in the services which we'd sort of recognise as being centred around older people. We have to be slightly cautious with this interpretation because here data quality is poor. We've got 40% of records with no team type recorded, but we've got 60% where it is, and this is what it's showing us. This potentially has an important impact for workforce, but also our 20% overall figure it sort of assumes that staff who are working with children could just transfer to older people services, but in reality that probably isn't the case. So our 20% overall for community services is going to be an underestimate because it needs more resource because the staff won't be in the sort of right places with the right skills. Jen? Okay, fab, thanks. So because the method that we've applied and also the actual source of the population projections from 2018 is used in our acute demand and capacity modelling, we were interested just to understand how those sort of pressures compared really between different settings. So here we can see the 20% figure that we've already talked about in community contacts, that's all ages obviously. And then we have the all age for the acute admissions, and that is all acute admissions. And it's roughly half at 11%. So really the pressures on community services are particularly sort of noticeable or significant, if you like, when it comes to thinking about demographic growth. For acute bed days, it is much higher, it's 18% growth over that same period, but it is still slightly lower than what sort of the level of growth that community contacts are facing. Thanks, Jen. So I mentioned before about how we'd used a sort of sample data set that we thought was sort of consistent internally and was of good quality. That sample was large. It covered 80% of all contacts in England that were in the CSDS. But we also wanted to reassure ourselves that this wasn't going to sort of be unrepresentative really for England as a whole. So we just compared sample data to the all sort of complete data set just to make sure that we were kind of happy with our results, and we did the same growth calculations as well in both ways, and they came out very, very similar. So we see here that the gender and the age group profiles are very similar between the all data set and our sample. We get some more differences by region, which you'd expect because some of the exclusions were for entire providers.
Did I get ahead there? Sorry.
No, you're good. So we did that one-off piece of work with the charts that I've just talked through, but there was also an interest in understanding what that might mean for ICBs and providing something that was a little bit more flexible. So we developed this tool, and it does basically the same kind of, exactly the same sort of approach to the analysis and data set, but it splits it by ICB, and you can pick your ICB and you can go and check your figures. We give a data quality breakdown as well. So really it's just this same information, but it's at a more local level. So hopefully, if I saw some people from ICBs on the call, but what we're hoping that this would do would give an ICB sort of a view of their community services and how they might be growing for themselves, because obviously the picture will differ across England.
So we thought that might be a good, it's only the first bit, but we're going to move on to a kind of slightly different topic. So if there are any questions about that or reflections on the approach or issues with uses of CSDS, then that would be this will be a good time to hear if anyone has a reflection or a comment that they want to make. Contractually, if you don't make any comments, then you're saying you 100% agree with everything that we're saying under all circumstances. Nathan.
There are. So yeah, sorry. Do Nathan first. There's a couple of comments, questions in the Menti, but let's do it with hands up first.
Hi, thanks. Yeah, sorry, my question was one of the ones in the Menti. It's just
that's fine.
Could you define what you mean by community services, please?
So to some extent, in this instance, there's a difference through the different processes that we're doing, because when we get a little bit further on to this left shift view, we're taking a holistic view of community services, as in it has a view of primary care and services that are happening. Essentially, from a policy perspective, it seems that community services is often viewed as basically everything that's happening outside hospital walls. Community is just not what's happening here from an acute perspective, and I think that that's a kind of very broad view that isn't potentially as useful. For this demographic growth element, we're defining along the lines of the services that are included in the community services data set. So that does it's often services provided by community trusts. I don't know, Justine, you'll be able to, including children and adults services, mostly a lot of district nursing and community nursing, reablement and those types of things. Where are we with mental health stuff? I can't remember, Justine, what's in now.
So that, and the demographic growth is just on what's in the CSDS. So if something around, there are some, I think, contacts, but they're very small. The vast majority is the district nursing, those big kind of services. Although CSDS, I don't think everything gets submitted there, but it is that sort of contact that's in the data that we've used.
Is that okay? Does that help?
Yeah, thank you.
Jonathan.
Yeah, thanks. I didn't sort of, I saw you presented the utilisation rates amongst people using community services, but what are they amongst the population? So presumably most people don't use community services in the way most people don't use hospitals. But I guess it'd be really interesting to see by age the population use rates of both community and hospital together, just to see, because if like 50% of people use hospitals and 10% of people use community, then you can see immediately the challenges of the left shift. I might have missed it, but I don't know if you presented that.
It wasn't a case of blink and you miss it. It isn't there. The reason it isn't there is because we've used this sample data, and it does cover a lot of contacts in terms of the 80%, but it's not all. So the exclusions are generally by provider because of issues around the attendance code. So whether or not the contact was attended or DNA'd or cancelled for some reason wasn't completed for lots of providers. So we were sort of excluding generally on a not completely, but generally on a provider basis, which makes that population need then quite difficult, because it would very low in some areas because we've had to strip out the provider information.
So how big is the gap then in your use of community services data? Like half of it missing or something?
20% of the data was excluded on the contact basis, but what we had left was representative. But I think there's just a final point about how community services data has been improving, and the data in 22-23 was affected by this particular issue at that point in time. But in 23-24, that improves, that recording of the attendance code became a mandatory field for the first time. So we hope that as should this work be repeated or updated, we would be able to go on and do that population or provide some sort of insight into that population need.
But like just now in the context of 10 million hospital admissions and 2 million community admissions, just the high level numbers would be really interesting, because I've no idea what the extent of use of community services is compared to hospitals, for example.
There's a really good King's Fund paper, and I've got a slide on it. So if I will try and dig that out at a certain point that can give us that comparative bit, because I think it is a really fascinating piece and part of what we need to look into a bit more. And I think it's also worth a nod to social care at this point in time, because a lot of community services stuff kind of links to older people. And in the neighbourhoods conversations that are happening at senior level now, I think there's quite a few people making the point that for the workforce for social care adult social care is the same size as the workforce for the NHS as a whole, so that this kind of general sense of the quantity of people who are accessing services holistically, whether it's medical or the kind of domiciliary care needs, is kind of huge. But I'll find that paper, Jonathan, and if I can't do it in this, I will send it over to you.
Thank you.
Chenu? Sorry, Chenu?
Yeah.
I'm sorry, I'm pronouncing your name badly.
Thank you so much. Yes, I'm Chen Yu from Northamptonshire ICB. Thank you so much for the presentation. Very interesting. And one of your slides is about the predictions of the growth of the demand of services, community services. What factors have been taken into consideration when you make the predictions of the demands? The growth in demand? Are you purely based on the growth of the population, or there are other things you also considered?
So for this piece of work, it was just the growth in the population, but we did that by the single year of age, gender and local authority, but it is just that demographic effect.
All right, thank you. And also, when you're thinking about the population growth, I'm now thinking, are you looking at the service, the users of the service, their age range of the users of the service? For example, the service is provided to the adults aged 18 plus, so you're looking at the population growth for that cohort.
Yeah.
Is that correct? Okay. All right. Thank you. Yeah, thank you for clarifying. Are you going to also publish the methodology paper alongside the findings?
Just finishing it off.
Yeah. And with for analysts, like the full sort of methodology, and I'm sure the code as well, if people would like that.
Yeah, thank you so much. Thank you. Yeah.
This is flying over, and I'm aware that we've probably taken more time, so I'm going to go kind of get to the kind of acute to the more acute end and identifying those things. So some of you may have heard about our new hospitals program demand and capacity model. We've built a probabilistic big data demand and capacity model for acute, and as part of that, and that considers, these are some of the factors that it tries to take into account. So some are already included, some are in process. As part of this understanding, which includes demographic change, non-demographic growth, and a number of other factors, there's this idea of activity mitigation. So what can hospitals or systems do to prevent future demand? And that gives us a real opportunity. This works through cohorts of patients. So the way that the model works is that it looks at HES data and it identifies 92 cohorts of patients where we think from the evidence that some of them might have acute care avoided and to their own benefit. And then we ask schemes in the traditional model thing to give probabilistic estimates of what proportion of activity they think might be avoided for those particular cohorts of patients. And then we run it through this probabilistic model. There's a lot of information on the strategy unit website about the details of that, but it's a Monte Carlo model, and it gives us a distribution of possible futures. And we've adapted it for this process to focus on the outputs of the activity that we think might be avoided. So the cohorts of activity that we're talking about are things relating to frailty in older people, end-of-life care, admissions, for example, where people are in hospital and they don't have any procedures or any kind of interventions, but they do die in hospital. So there's a question of, is that the best place for them? People with hospital frailty scores and frailty, where we think that there might be opportunities to do more in the community. Reductions in length of stay for older people in general, because that's something that has been tracking down over time. And so is it something we can do more on? Things like ambulatory care sensitive conditions, some public health interventions like or considerations like smoking, obesity, and admissions relating to alcohol, couple of specific virtual ward ones, and medicines related admissions. So of the 92 altogether, we tried to pull out the things that we think are most in what we call the purview of mitigation, most in the control of systems and settings, primary care and community care outside of the acute hospital. So something that needs to be worked in partnership and that might deliver this left shift and also some degree of prevention. It's worth noting here that we've been talking about trying to achieve the left shift or mitigation for many years. As I said at the beginning, we've done some analysis looking historically at what's happened, and it's worth just looking at the non-elective admissions as a key point here. So often shifting care out of acute settings, we view it as, we've identified that a lot of the activity that might be shifted sits in this non-elective admissions space, and the activity that we think is non-mitigable, so it really has to happen in hospital, that's been growing relatively slowly in line with growth in the population since 2011. But the activity that we think could be prevented or could be redirected and put elsewhere, despite the fact that we've been saying we want to shift it out of hospitals for all of this time, has actually been going up, and not going up in a small amount, going up a lot. So there's some context around this about, we're saying that it's possible to do this, but actually we're working against the trend that's been happening historically. And there's some more information that we'll share about that over time. There's also a very complicated topic about non-demographic growth. So we know that that things like the changes in the way that hospitals do their activity, new medicines, new technology, and a number of other factors mean that there's been growth in hospital activity that's over and above what we might expect for demographic. So you'll see a bit more detail in the detailed write-up, but we've done some elicitation and consideration of what we think that non-demographic growth might look like in the future that we're going to have to counteract with this mitigation. But this topic does blow all of our minds, and we could talk for 40 years about this on its own. So I'll just skip over quite quickly. So what the model's allowed us to do is to draw out who those cohorts are and the volumes of activity that we think, who are these patients, what's the size of these cohorts, and what is the volume of admissions and bed days associated with each of these cohorts. It's really important to note that many of these overlap. So some of the frailty and falls cohort might exist in emergency admissions of older people. So you can't add all of these up. But from a targeting perspective, when you're thinking about what interventions might make the biggest difference, it's really useful to be able to look at these in an overview and see what the kind of size of the opportunity might be. So that was one of the first outputs that we had for NHSE, and it's worth it. I mean, obviously, emergency admissions of older people is huge. That's the one where we think we might be able to reduce the bed days, but there are some other kind of key points to note: admissions with mental health comorbidities, frailty in older people being really key here. And it's this idea of being able to explore the cohorts of potentially mitigable activity is also something that we're trying to develop into a tool that ICBs can use. So we've looked at age and sex standardized rates and how bed use varies across the country and between ICBs from the HES data, and that's something that we might well come back and talk about. There'll be lots of factors affecting this. We know that deprivation and structures, and we're exploring the many reasons for variation. So this isn't a performance metric. It's a way of trying to understand the difference between areas and how we can really understand the causal factors and what might make a difference. But that's something that we want to draw your attention to. But for example, Dorset in this chart, you can see have had quite a significant drop in the number of people dying in hospital, and also quite a high, I can't remember how to anyway, Dorset doing well. It's going to be interesting. We'll explore that variation. I'm going to skip over that. We'll come back for it. So this first part, potentially mitigable activity, is something that we want to talk a bit more about, and if people are interested in exploring that with us, then please do get in touch, because I think that's something that might be useful. For the modelling, what we did was we looked at those scenarios. We tried to set the ambitions for how much activity might be shifted, and we did that. We looked at it in 3 ways. First of all, steady state. What happens if we do nothing? Second of all, from the NHP schemes who've run the model in the past, what do they think is going to happen? What do they think their opportunities are to make this change? There's been 18 schemes who've run this through, where they're planning a future hospital. They've spoken to their clinicians and developed a view. Let's use that view for a national perspective. And then we also did an expert elicitation. So we spoke to a number of clinical experts from various community backgrounds, and we asked them, if you had the money and the resources, how much of this activity would you be able to shift? So it was a bit more of an ambitious ask of, you know, what do you think is possible, not necessarily what do you think is probable. And because we're trying to work probabilistically, we try to incorporate the idea of ranges of views here. And I think so these are the NHP Trust ambitions, and because they're more resource constrained, they're less optimistic in terms of the amount of activity that they think can be shifted, which makes a lot of sense. The expert opinions were really broad. Like, even with that extra money, people very much differed on how much difference they thought it could make, which, given that we've not been successful from a policy perspective in the past, makes a lot of sense. But it's worth noting that, you know, the ranges of how much shift people thought could happen were really, really broad. But you can also see that people felt like things like end of life care admissions or frail elderly admissions were the places where there was the most opportunity to shift. So we ran that through the model, and again, the two big things that we try to pull through from the NHP model are, firstly, let's think probabilistically. So we're not trying to do a pinned point of where the future is going to be, but we're trying to think these are the range of scenarios that might exist in the future. And the second is the mitigators. So this bee swarm chart is a way of looking at what we think the future projections of bed days is going to be. And it's worth noting that we run these 250 scenarios, and some of them were pretty low, and some of them were pretty high. But even in the largely unconstrained with extra money, there were still scenarios in which we would still see growth in hospital care. But a lot of it, and our best guess is for the unconstrained scenario, quite a reduction in bed days. And this is the overall what we think is going to happen to admissions. So the steady state is a really big increase in admissions. If things keep going as they are in terms of population changes and other changes, the pressures on hospitals is going to really, really rise in admissions. If the scenario that the schemes were suggesting comes about, then that will reduce the burden on hospitals, but it's only going to turn that curve slightly. It's not going to change the need for more beds in the future, or more admissions happening in the future. Largely unconstrained brings that down a little bit further, and there's something, and these outer bounds give you a sense of that probabilistic view. So, you know, whilst we're saying this at the midpoint, there is a broad range of uncertainty, but we're talking about reducing the volume of admissions in this context by about 15%. But it has a much bigger impact on bed days. So again, you're only turning the curve slightly if you're using the average system plans. But if this investment were able to follow about community services, you would see a reduction in the number of bed days happening in the acute sector. And we're talking about a kind of a 39% as the midpoint reduction, again, with a wide confidence interval. And it's worth noting here, we're talking about 55 million bed days. When we're talking about bed days here, it's a count of days, not midnight occupancy. So essentially, yeah, so it seems larger than the midnight occupancy numbers that you would get. You take off the number of admissions from this number to get to that midnight occupancy number. And we can answer some more questions about those ways of counting in the future. So on this largely unconstrained scenario, we can kind of see what the effect of these different changes have been. So the baseline is the amount of activity that we're projecting that's happened already. Demographic changes account for a little bit more. Non-demographic changes account for a little bit more. There's something called the model interaction term, which is to do with the way that our model works and the probabilistic nature and how we can line up our understanding of the way that all of these things interact in this particular model. But activity avoidance is a really big part of the impact on bed days, and then efficiencies, by which we mean reductions in length of stay, also has a significant impact. So you're left with a reduction overall in the number of bed days that we would expect to see for the horizon year. And we're able to put the to look at the specific mitigators and to put the two scenarios side by side to try and get a sense of who are these patients that we might be able to be targeting, what's the scale of admission avoidance that we would see for each of these groups of patients to try and help people target. So things like admissions with no overnight stay and no procedure, you could imagine we consider is something that can be reduced quite significantly. But it's also worth noting the importance of, again, frail, elderly, ambulatory care sensitive conditions, so the chronic long-term conditions. And you can see that there's maybe some useful value in how we can differentiate between where to target the attention towards these particular cohorts. I need to go more quickly. This is the admissions avoidance one. So again, this is bed days. So you can see that it's more that frail elderly emergency admissions within 28 days are really important here. There's also acute dependence on prevention mitigators for in the impact on bed days. And reduction in length of stay for emergency admissions of older people is a really big factor alongside admissions with mental health comorbidities. So we don't have time for many reflections, do we? Should we pile through and then ask questions at the end? Justine, I'm going to pass to you for transformation of that to community resources, and also for you to mop up anything that I said wrong.
I don't think there's anything wrong, you're fine.
Right.
So if we want to think about the impact on community services from taking things out of the acute under any scenario, we need a sort of way of translating that into a cost for community services. We struggled to find good sources of information on this, but we did have something from Monitor, which is back in 2015 now, so it's been around for quite a while. But the work in the Monitor report suggested that to move things from acute into the community would be roughly, it was based on several sort of key community interventions, was roughly break even over a 5-year period. So that therefore meant that we had an assumption in our analysis of cost equivalence in that £1 that you had to take out of the acute, you would need that £1 back into community. So on the next slide, I think it's the next slide, we looked at what is the acute cost, because effectively with the Monitor assumption, we're going to move that acute cost into community services. So the model data for the sort of different scenarios of avoided activity has got the HRG code.
We lost Justine. What does that mean?
I can't hear either.
She was having network problems earlier. I'll take over and hopefully she'll come back in. So we've got the HRG codes from the model because we've got that line level data. So we took the costing information and added it up in terms of what's the tariff that the acute sector is receiving. And you can see this breakdown in terms of 3,561 million in emergency care, and you can link it to the bed days here. So that gave us a £3.7 billion cost in terms of this average system plan HRG code costing for in acute for the avoided activity. So where people haven't gone into hospital. And then in addition, there is the bed days cost, which is calculated slightly differently and maybe slightly different in terms of how avoidable it is, but it also adds another significant chunk on to that costing. And if you have the largely unconstrained, it's much more. It's kind of 8.5 billion with upper and lower values here, plus the additional costs avoided from the efficiencies in bed days, which are often only managed if you actually shut wards and things. So we took the average system plan as the kind of more realistic scenario, bearing in mind that it still only turned the curve in terms of future demand for hospitals. And we compared it to what the baseline community services budget was. Now, interestingly, there isn't a consensus on how much money we spend on community services. So we took this, but there was a question to Parliament in which they provided this information, which said 11.9 billion is the cost of community services, although it excludes continuing care here and doesn't look at primary care services. Nuffield had a different view, Standice and Community Health Services had a different view, but it kind of works out in the middle of the different estimates that people brought out. So given that, and it's also worth noting that, so given that, we're going to need to shift that money over and to fund workforce and community services. And it's just a useful bit of context to note that over this point in time, the number, over the last 20 years, the number of district nurses has really, really fallen in community services. So shifting that money doesn't necessarily mean solving the workforce problems that we've got in that context. But if we take the maths and the logic of what we've done before in a fairly simplistic view, there's a 20% net growth in community services, which we're expecting from demographic growth. And then you saw 3.7 billion pounds of activity that needs to shift, even if it's just the NHP and even if it's just the activity avoided elements. And if we consider that that is going to be the equivalent cost in community services, we can look at the proportion of the 11.9 billion pounds that we spend on community services that might relate to 3.7 billion. So adding those things together, 20% here, this is 31% of the current spend on community services. If you add those together, then you get to a point of we would need to grow community services by 51%, even just to slow that curve and manage the change in the way that we're expecting by the horizon year of 2035-36. And as I say, that's still to achieve this aim, not necessarily this aim of actually turning things around from being fixed in the acute hospitals. So this point here, the 51% of growth that's needed and the kind of volume and which cohorts of patients it was, is the things that we fed in to the to NHSE, and that's been used for the future modelling. And as we said at the start, it's very much using the data that we've got in the best way that we possibly can as a starting point to try and understand this. And we're looking to iterate on it and build it. This is a rapid piece of work, but we think that it provides a way of quantifying the interface between acute and community services and primary care in a way that we haven't been able to do before. 1 minute left for questions. Sorry, Rachel, we were slower than I was expecting. Oh, great.
You won't be able to do all these. So I have a proposition, Jen.
Mm-hmm.
Are you up for this? So I think there's some really good comments and some really good things which not necessarily challenge the approach, but there's certainly things that we need to have answers for, you know. So whatever is produced, there needs to be sort of like a Q&A as to what's in and the response to it, and, you know, the caveats and so on, which there will be in, and no doubt in the final paper and the methodology and so on. So I just think there's some really good points there that we sort of need to think about, and I will share all of these with you after, so you're not missing out on some of this really good thinking that people have come up with.
Yeah.
Is that okay?
I think that'd be really helpful. I think that just the first few things that we were noting, you know, getting back to that point of community services, the CSDS data set is only covering a small part. And I think one of the things that we're going to try and work on more linked to the New Neighbourhoods programme is a broader understanding of community services. How do we include primary care? How do we include voluntary sector? How do we include adult social care? I think that's really useful. And some of these other comments will be really helpful for us in both developing our understanding and our tools, and we can share those things on. And we'll be publishing the paper, I think, in the coming couple of weeks with the detailed analysis in it on the strategy unit website too.
So people who've contributed can be reassured that they are being listened to and they are being incorporated. No, thank you ever so much for sharing that with us. It's an ongoing piece of work, I know, and it'll be improved as time goes on again and again and again. So thank you very much for sharing what you've done so far. Just before, if there's anybody still left on the line, just to share what we've got coming up in the next few huddles, we still would like to present to you the actual new hospital program demand and capacity model. We've alluded to it several times. I mention it virtually every single huddle, so we will have that. But our next huddle is humans, AI, and the importance of data literacy. That's with Dan Isaac. I really think that's going to be an excellent session, so you should come to that one. And the one after that is HEU colleague talking about, I think she was on the line today, she might not be still there now, but a model to assess the costs and benefits of investing in initiatives to increase HPV vaccination and cervical screening. Hacker is on the list, and so we've got some other things there which people can look forward to. And we've just very quickly before we go, just want to mention again about the understanding and reporting hospital mortality stats. We've always I do too. Hospital mortality statistics. So we've got an online session with Mohammed. That's on the 24th of June. So we've got like nearly 160 people signed up for that so far. Please don't tell Mohammed, he won't turn up. But I'm going to be there to sort of smooth the way, distract him. That's online. So please, that's free. It's you need to know more about this. We're still using these readily in all of the assessments of it, in particular of acute providers. So please do be in the know and understand that in more detail, so that you can also sort of challenge how they're being used. The in-person one is sold out, but if you register for it, I know the links aren't on here, not very helpfully, but if you register for it and pop yourself in a waiting list, that will tell me you do want me to put another one on, I'll do that. We got an RAP session next week with Chris Bealey. The CDAON have put out, you can apply for bursaries with them. So the deadline for that is the 13th of June. Just search that up. HSMA showcase event, mentioned that before, and all of these I think mention in the email that I sent to you, and I'll do that again. That's on the 24th of June. That is an excellent course. You really should get involved with that, or get people in your team to get involved with that if you possibly can. And then we've got the AFA fortnightly lunch and learn sessions, which again, I went to one the other day, really good on Gypsy and Roma communities and needs assessment around that, and so it was really good. So that was that. And thank you everyone for coming. Who's still here? 39 people are still here. Tummies must be rumbling. I'm going to go and join Andrew Barraclough in a session that they're doing on analysts and decision makers now, because that looks really good. So I'm going to hold off from my lunch, and I'm going to go and enjoy that. Thank you, Jen. Thank you, Justine. I know she's trying to get back in desperately. Really thoroughly enjoyed the session, and thanks everyone for coming. And I'll see you all in a couple of weeks. Bye bye.